Hi, everyone, and welcome to our SIG webinar series. This is our second webinar that we're doing, and we have a great topic this time. I'm very excited about, which is EENACOMA, model of care for disorder of consciousness, and it is I'm delighted to introduce Willemijn van Erp, who accepted to present that project that she has been working on for so many years. I'm very happy that she accepted to present this, and she has dedicated her professional attention as a scientist and physician to patients with the most severe sequela of acquired brain injury since 2011, when she wholeheartedly traded the acute neurologic practice for long-term care medicine. She registered as an elderly care physician, nursing home physician, a medical specialty unique to the Netherlands in 2018, and obtained her PhD at the University of Nijmegen in the Netherlands and Liège, Belgium, in 2020. Currently, she combines a postdoc position at the Radboud UMC with clinical positions at Accolade Zorg and library rehabilitation and audiology in the Netherlands, always in a nationwide network of expertise called EENACOMA. So without further ado, Willemijn, Dr. Van Erp, please.
So if everything's okay as we planned, you can now hear me and see my presentation, right? Is it working?
Yes.
Okay. Oh, great. Okay, I'll start then. So thank you very much for granting me this stage. It's very exciting to be speaking to this international audience, and I'm always also very happy just to be able to share what we've experienced in the hopes of helping colleagues abroad fulfilling their mission. So yeah, as Caroline said, my name is Willemijn van Erp, and I combine all kinds of clinical work with research, and you've already heard about my affiliations. So we're talking about prolonged disorders of consciousness. That means that a patient after an acute injury to the brain shows no or only minimal signs of consciousness for a certain period of time. It usually targets younger patients, and the care for these patients is complex on all kinds of levels, most importantly on the somatic and ethical level. And I always feel like you can look at PDOC as a product of modern medicine. If we weren't so advanced in our acute care in the ICU and the emergency room and in the operating theater, these patients wouldn't be in their states at all. So I always feel that makes us extra responsible for caring for them after that too. And I think many of you probably are involved in this quest for optimal care for PDOC patients. I would say that it could be defined as it should be evidence-based, it should be personalized, but it should also be societally sustainable, and that's quite complex. I'm going to take you through a couple of cases that are based on actual cases, but they're all anonymized. So the first is Manuela, who's 43. And she suffers a subarachnoid hemorrhage, really bad one, at 4 weeks post-injury. She's in a minimally conscious state plus. But in the context where she happens to be in, there are no rehab options at all. So she's transferred to a regular nursing home surrounded by mostly elderly fellow patients, where she develops in the weeks after a very severe spasticity. And her physician, who is a general practitioner, keeps looking for the focus for the fevers that she keeps developing, but they don't find it. And in the end, they resort to a pretty strict regime of benzodiazepines, which does seem to relax her a little bit, but she develops then an aspiration pneumonia and she dies at 12 weeks post-injury. So in this case, we have a lack of recovery targeted treatment. The complications that Manuela develops are not managed in a way that we would like to see it. And in general, she has an undertreatment. Maarten, who is 55, has been in an unresponsive wakefulness syndrome for 12 years following a resuscitation while he was running outside, and his mother still visits him every day in a nursing home, but he also has a wife and children who don't visit him hardly anywhere, any time at all. They haven't been around for at least 6 months. And when you ask them why that is, they say, well, we have such trouble seeing our loved one like this. He would never have consented to be kept in a state like this. The nursing staff also has serious doubts about what they're doing, who they're serving with this intensive care that he still receives. A key problem in this case is that the patient cannot partake in their shared decision-making process. There is an evident moral dilemma about what good treatment should look like for Maarten, and potentially this is a case of over-treatment. Then Fatima, who's 62, is admitted to the hospital because of a COVID infection, but develops a cardiac arrest there and sustains severe post-hypoxic encephalopathy. After that, she's diagnosed with an unresponsive wakefulness syndrome, but she's somatically super unstable. Despite all kinds of measurements, she just goes from one infection to the next. And she shows a lot of signs that could be interpreted as discomfort or even pain. However, her family members insist on continuing the curative treatment and say that this is part of their religion. And the emotion gets so high that it even leads to physical aggression targeted at the healthcare workers. The police gets involved. And at some point, some of these professionals are heard saying things like, there's always trouble with those Muslim families. So in this case as well, you have a patient who cannot partake in the shared decision-making process, and this very serious moral dilemma with aggression, but also with an aspect of diversity that is not addressed adequately. And you could argue whether this is under or over treatment, but in any case, no one is happy. So this optimal PDOC care that we can all picture, I guess, is not something that's realized very easily, and there's a lot of stake as well. There's the patient's well-being that's at stake, but also the family's well-being, that of the healthcare professionals, and also a lot of money. I've seen time and time again that the lifetime costs of caring for a patient with PDOC exceed about $1 million. And this really this exceeds, obviously, if a patient is in this state for a longer period of time. So I'm going to take you to the Netherlands now. It's a super densely populated country. Apparently our children are the happiest in the world. The adults are too, and they feel that they're pretty much invincible. As you can tell from the picture, we don't wear helmets when we're cycling. But we have good healthcare, which is very nice, which includes the rehab and long-term care. What wasn't so nice for a very long time is that the care for patients with PDOC was very, very fragmented. When you were older than 25 years of age, you would not get any specialized rehabilitation. You would go straight to long-term care facilities. And when you were younger, you would get only a maximum of 20 weeks of specialized rehab. There was no scientific involvement in the care of these patients on a daily basis, and we had a lot of misdiagnosis. And on the other hand, there has been a statement from the Royal Academy of Medicine that still, as far as we know, the furthest, it goes the furthest all around the world, that stated that when a patient would not have chances of recovery of consciousness, a physician should discontinue life-sustaining treatment, even if the family insisted on continuing. The idea behind this being that as a patient, you should be able to trust your physician to discontinue treatment, to let you go if there was no perspective of you recovering to a conscious state. So we've argued in one of our papers that this led to a vicious circle. You have a very rare condition, you don't know what its prognosis is. The treatment that you offer is suboptimal. This leads to a context that facilitates the tendency to discontinue treatment. And that brings you back to point one. You still have a very small group of patients of who you don't know what it could have led to. And we've also seen that undertreatment in these critical first weeks to months after the injury may lead to overtreatment in long-term care, because families will be traumatized by the way they're treated and the fact that they're not being heard, that their loved one is not being seen for the potential that they might have. And that makes it very difficult for them to let go, even when the prognosis is very, very clear. There have been quite a few cases in our experience that even when it was not possible at all to talk about ceilings of care, for example, but the family members would say, well, of course, we know that he never would have wanted this, but with everything that happened, we can just kind of let him go. I see these red lines here below. I'm not sure where they came from, but I do think that you can read what's still the slides say. And I think, Caroline, we've said that questions will be asked at the end, right? But if the moderator sees something that should be addressed right away, then just let me know, because the idea is that we exchange ideas and opinions and expertise too. So it was very clear to everyone in the Netherlands that something needed to change. And there's a couple of steps that we took in that. First of all, gathering facts. We needed to create consensus. And we needed to generate societal momentum while trying to minimize incentives that were not patient-oriented. And I'm going to go through that with you. So gathering fact is really about research, and preferably with a broad group of people behind it. So one of our current research projects is funded by the Dutch Brain Foundation, but there's also the health insurance companies involved, and both have dedicated their commitment to implement the results. When you're gathering fact, you're really not talking, even though that might be a shame sometimes, you're not talking about high-end technical interventions or diagnostics, but about very basic facts, really. So the incidence, the prevalence, and measurements of quality of care, so that you can say, well, this is the group of patients that we're talking about, and this is what we would like to offer to them. And these themes are a part of that too. And you want to attribute so sort of meaning to, for example, the functional outcomes of a specific rehabilitation program. Unity amongst the stakeholders is very important too, and collaboration is obviously a very big part of Sesame Street, so I'll just put that here for you. This means that you should gather your healthcare professionals, but also experienced experts and governmental bodies at the later stage, though, and see what common ground you have. And in that, we found it's very important to acknowledge that, in a way, many of these individuals, but also organizations, have been scarred by just providing decades of care without sufficient support, with always having to argue why they would need money, why they would need reimbursement. And it makes it very hard for institutions and individuals as well to be open about what they're doing once they want to start collaborating. This really takes time. We find in sometimes when times are hard, you can see that we get back into the reflex of just closing the door and looking mostly at what we're doing for ourselves. In this process, it helps if you say, well, out loud what you don't agree upon and what your motives are. In the end, you usually can find common ground, and that helps to get across one message, a really simple one, preferably. And this is what you need to get that message across. We've always been very inclined to talk about what we're doing, whether it's research or clinical work, in the public domain, specifically because it's ethically charged as well. And this helps creating unity, and but also obviously in fundraising. And this is a really important part. Many policymakers, not all of them, many really don't have any notion of what high impact journals are, and they don't read scientific publications. But if you're in a newspaper or you've been on the national news, and that's what they're looking at. And it's a really helpful thing if you can just say, well, you can look at that and hear and read what we've been doing over the past few years. And this is something that's probably the least easy to change if it's different than what I'm saying here. So the Netherlands have a relatively free of commercial party system when it comes to healthcare. Obviously, prolonged disorders of consciousness, end of life issues, disability are very easy to hijack by political or religious forces, but also commercial parties. So, and that usually doesn't really help. So I think it would have gone very differently if that would have been changed in our country. So looking at our specific context, these are the milestones that you can identify. So 2014-15, we did a nationwide prevalence study on unresponsive wakefulness syndrome. A nationwide network of expertise, EENACOMA, one after coma, was established in 2016, which and this is chain-wide. So there were acute care specialists, but also experienced experts, people from long-term care, post-acute care, etc. And this network generated a report called Appropriate Care for Patients with PDOC. And this was really a wish list. So we literally wrote down, based on our experience and the international evidence, what we thought, what kind of care should be provided to these patients and how it was going at that stage in time. And lo and behold, obviously this helped generate the societal momentum. You can see here that the Dutch Brain Foundation helped us realize this report, and we got a lot of media attention for this as well. And then the next year, this infamous age limit for PDOC was finally lifted, and we were able to construct this novel chain of care, which I'm going to talk about just now. And we also did that right away within an academic context. So we started a nationwide cohort study, which resulted in almost all patients with PDOC now being included in a central registry. But obviously, this all didn't just pop up out of nowhere. There was literally decennia of hard work preceding all of this. Much of it was done when it wasn't even born. And I'm just going to take the time to mention a couple of key figures in that. So the first one is Jan Lavrijsen, elderly care physician and researcher, Hans van den Bos, and Henk Eilander, and Raymond Koopmans. These four people, I think we wouldn't have come this far at all, or even started, when they hadn't done what they've been doing for so many years. So this is what the chain of care looks like right now. Obviously, it starts in the hospital. When a patient there is diagnosed with a prolonged disorder of consciousness, they are eligible for early intensive neuro rehab. This is all concentrated in one center with 14 beds, up to 14 beds, I have to say, and conducted by a physiatrist. if during the early intensive neurorehabilitation, a patient does not regain consciousness, that's in about 50%, the patient is eligible for a prolonged intensive neurorehabilitation. That's concentrated in 4 centers and conducted by an elderly care physician, such as myself. Patients go out of this chain of care to various institutions. The regular neurorehabilitation is quite difficult. We find once you're conscious, very often you're not you're not structurally well enough to go to a regular setting. Some people go to chronic care and others go to palliative care as well. And we have a mobile team of experts. The mobile expert team I'm going to talk to you about a little more, that moves throughout this chain of care. Because obviously, as many of you know, one of the major challenges in PDOC care is the diagnosis. Misdiagnosis we've been talking about is super common when you use the behavioral standard assessment to verify the clinical consensus. You see a very big discrepancy there. But even if you do this optimal diagnostic process with the CLSR, you will still have 15 to 20% of patients that you're underestimating their level of consciousness in. And this is a really big problem. And it makes sense if you just go back to a little more basic level and think of what is needed before someone can give a conscious response. First of all, the stimulus needs to be adequate. Patients need to be awake. They must have some sort of sensory devices that they can hear or see with, which is very often a problem in our patients. Then you need to be able to rely on all those neurofunctional systems that provide conscious awareness. Once you're consciously aware of something happening, you have to be able to initiate some response, which is a problem, for example, in akinetic mutism. And then when you've passed that stage, you need to have some form of output. You need to be able to speak or to move. So this is obviously what has beautifully been shown by Owen and Laurijs and many other people after that this is actually a problem. Anywhere along this chain of events, something can go wrong, leading for you to not be able to give a conscious response. So what we realized was that a good diagnosis was a prerequisite for personalized and appropriate care for our patients. It's about knowing that someone's able to suffer, that they're able to enjoy things. It says something about their recovery potential, but also on a very existential level, it's about being recognized as being there. And it's something that I wrote something about with Bert Keizer on a more philosophical note. Just to resume, it wasn't going so well regarding the diagnostic quality in the Netherlands. And we realized that our experts were much easier to move than our patients. So we should devise a mobile team, and that's what we did. We spent quite a lot of time actually to develop this mobile expertise team, and we're now implementing this. And this is what the mobile expert team provides: basic diagnostics, which is behavioral diagnostics, accessory protocol. We give various forms of therapeutic advice, and we have moral consultation and family counseling as well. And the framework of what within the MET operates is that we always go in only on request from the treating physician. There's always a lot of families contacting as well, but then our response is always, well, please bring us in contact with the treating physician of your loved one and we can figure it out. Because if you just go ahead and just visit the patient without the support of the people that are actually in charge, no one is helped by that at all. There's going to be a central desk linked to this EENACOMA network of expertise. And for now, and I think the coming years, it will be free of charge. This will be really a service provided from post-acute and long-term care settings to the acute care. And the team consists of a group of supervising consultants and regular consultants, and we have a pool of experts that are just flown in based on the cases that are brought to our attention, and a couple of permanent members. So just to go back to our cases to give you an idea what that has changed. Manuela, who had no rehab options, right now would be given a consultation by the med, who would give an indication for early intensive neurorehabilitation, where we can deal very well with this PSH and other problems that she has, because obviously this fever without focus would be most likely a paroxysmal sympathetic hyperactivity. And then she would regain consciousness and eventually build a new and good life for herself with the help of anyone who can help her with that. In a case like that of Maarten, you would get a med consultation to result in a moral deliberation. We have the possibility of temporarily admitting patients to one of our prolonged intensive neurorehabilitation nursing homes, so that we can look at the diagnosis there, but also give a little rest to the patient's family and also the referring center. We always see that gives a huge relief. But it's seen in his case that there are no therapeutic options. The family gets specialized counsel, and when we reconstruct the patient's wish, everyone agrees that there would not be consent for continuation of life-sustaining treatment, after which he is referred back to the nursing home he was living in for palliative care. And he died after a peaceful week of palliative care. And looking back, the family said, well, we should never have gone this far, but it is good that he is at peace now. Then Fatima's case with a very big conflict. A very important thing that we've learned is that safety for healthcare workers is a basic need when you want to give a patient proper care. So this is a sensitive topic, but we've seen that if you really, and it shouldn't be the individual healthcare worker that sets these boundaries, it should be the board of directors. We've seen then you have a good new starting point and seeing how you can get together and resume the care and the conversation that you need to provide this care. So after this, the son is appointed as a legal representative there, and a moral deliberation is organized. There's also intensive counseling for both the family and the treating team, and education really about the different spiritual aspects of this case. Meanwhile, the diagnosis and prognosis of Fatima are confirmed as well, and they decide based on her reconstructed wish, which is according to her religion, that she would really want to go and see whether she can live through this. But it's also agreed that she should not suffer if we can help her not suffer. So she gets some symptomatic treatment as well. She goes eventually to the early intensive neurorehabilitation ward, but dies from a pneumonia despite intensive treatment. And after that, everyone involved feels, well, and mostly the family, at least we tried everything. So the implementation of the MET is quite complex. So we've been conducting a pilot for the last year, which is paid for by the specialized nursing homes. And we were trying to find out what questions there really are in the field, what we need to be able to do and when. And this last point, how to position this cross boundaries team within the existing structures that underlie our care system. So this is where we stand now. This is a very good thing because it's not just me providing these consultations anymore. We have a resident doctor who's helping us, a medical secretary too. And we get about 2 requests a week, 1 consultation on site a week. Mostly it's at the beginning of the chain of care. So in hospital basic diagnostics and then referral to the early intensive neurorehabilitation. But in 20%, it's more complex than that in a mostly ethical sense. And we find that where we do have the knowledge and the experience to live up to the standards that we set for ourselves, so we can answer questions, we can really help families and healthcare professionals with all the knowledge that has been built up for the last last decades really, in our settings. But then we're going to the more bureaucratic part of the story. So you have mobile experts, but the money is super mobile as well, because the money is going from the government to long-term care. We use that money to bring it to the acute care hospital, the academic hospital that's covering the mobile expert team and also our knowledge network. So the MET is organized within the academic hospital. The MET then sends the money to the experts that are still based in long-term care or in post-acute care, in order for those experts to make time to see patients who are usually in acute care again. So, and this is just the money streams, which are very complex. But if you're going to talk about who is responsible for which part of the quality assurance, even legal aspects, that's, yeah, I can say that we underestimated that a little bit. But well, so and we're still working on that. And this is a picture of the Perseverance roaming Mars. I think as we speak, even still, that's definitely what you need. And also, what's vital for all of this is, for example, in negotiations with people behind the money, behind these structures who are just getting stressed because we're doing things that the system really won't allow, even though everyone agrees that we should do this for the sake of the patient. You really need to be able to show that you're combining this clinical expertise with your research work, that you really know what you're talking about, but also you need to have time for the societal translation. And there's only a small group of people that can do that. Usually, and I don't think it's very different for any other country. While at the same time, the professionals in place in the financial sector and in the governmental positions, they do have a super high turnover. So we find ourselves again and again explaining what prolonged disorders of consciousness are and why we're doing all these complicated things. Yeah, and no, we've taken this decision before with your predecessor, etc. And yeah, this is really, it needs to, well, you really need to persevere, but also you need to do so with some kind of positivism, because there's something that we've seen is that once you get a little bitter, no one listens anymore. So in some way you need to keep up your good spirits. And I always find that it helps to just look at the patient and see, well, things could be so much more worse than what we're dealing with here. And in the end of the day, I'm just happy to be able to cycle with a helmet though back home to my family and know that at least I've been doing something useful with my day, I guess. So what we still have on our list now is to implement this mobile team of experts, to get structural financial support for the early intensive neurorehabilitation and the prolonged intensive neurorehabilitation. We are quite optimistic about this, I must say, but we should never be too optimistic. Continue research, kind of zoom in on that a little bit, because there's a couple of themes that are very important in helping us keep the system going the right direction in order to serve our patients. And that's, first of all, the diagnostics. epidemiology and prognostics, and treatment, which includes the medical decision making surrounding life, end of life decisions. And well, I'm very happy that we have these are the PhD students working on this. So currently they're from various institutions. Doctor and TopDoc is our big cohort on the outcomes of our novel chain of care. We've done a prevalence study. Berno Overbeek has done that on MCS. We're working on deep brain stimulation in MCS as well, and on in akinetic mutism as well, looking at moral deliberation. And we still have currently we have two research proposals that we're very excited about, that are very far in the review process. And well, if that works out, and I'm going nuts, I guess, but that's really going to help us bring all kinds of things together, specifically regarding the qualitative research, ethical research, and the neuroscientific part of caring for patients with PDOC. So this all should facilitate us in improving our care programs on these different levels. While we should still always keep caring for our carers, because yeah, if they keel over, then you really have a super big problem. So yeah, I've been talking a lot, so I just want to pause here and see how you think our experience can help you. And of course, I got a take-home message and things that we can talk about with the moderator as well, but just a little pause here, I guess. I'm gonna stop sharing my screen. Yeah.
It's wonderful. That's so inspiring. I mean, you know, I think that there is a few questions that according, you know, among them there was, and actually I have the same question. Do you have that report that was published in 2018 in English? Is it available?
Yeah, I think it is in English. So I'll get back to you with that, so we can send it to everyone.
That would be something that would be so helpful. I think that, you know, even with the IBIA, that would be great to create some collaboration or whatever, to try to, if some centers are interested in developing MET, so mobile expert team, that they are able to. I think there were some few questions about the MET team and if they involve technique you know, evoke potential, or some more evolved technique that you would apply to the bedside, or is it just you know, CRSR and behavioral assessment, and what type of discipline is involved in that team? And then I have more question, but I will start with
great. So the current team is still mostly me, which is an elderly care physician, and we're providing this bedside behavioral assessment together with the physiatrists as well. And we found it's still very difficult to get the accessory diagnostics to be reimbursed. So what we've managed just in a couple of individual patients now to get a very large and extensive EEG with accessory analysis as well, and FDG PET, and that seems for now to be the most feasible goal to go at first. But then we have to discuss the financial reimbursement of that with a different set of bureaucrats, because those techniques are all harbored in the hospitals. So that's a very different money stream. And I just sense that it's going to take some time for us to get that just structurally financed as well. Yeah, and how we picture the team in the end is that it's in this pool of experts, there should be neurointensivists as well, but also more social workers and pastoral workers, so that we, next to the consultants who are physiatrists, elderly care physicians, residents and very experienced nurses and paramedic colleagues.
I have another question regarding the prolonged neurorehab nursing home care. Could you elaborate a little bit on what that involves?
You mean the prolonged intensive neurorehabilitation? Yeah.
Prolonged neurorehabilitation nursing home
yeah,
care,
exactly. Yeah. So the first chain in the chain of care is the early intensive neurorehabilitation, and during that time, that's in one of our that's in just one medical specialist rehabilitation center. Patients get up to 25 therapies a week there. And after they move to the prolonged intensive neurorehabilitation, which is usually at 14 to 20 weeks after their admittance there, we have much more time in PIN. So we can extend PIN for up to 24 months after the injury, but we have a lower frequency of therapy. So that's about 10 therapies a week. But they're still multidisciplinary, directed as eliciting conscious responses, facilitating communication, promoting well-being, and getting the proxies involved in a healthy way, and also the advanced care planning is a big part of that. Next to obviously the very intensive nursing care that these patients still and medical care that they require.
So, are the candidates for this care transported to these very expert team center, or is it that you have several of them across the country? So how does it work exactly?
Yeah. So first the team travels throughout the country to see the patients on site who are still in hospital but have been referred to the specialized chain of care. Then when they are indicated for our specialist chain of care, then they go to the early intensive neurorehabilitation ward. And from there, they go to, if they need it, to the PIN institutions, which are 4 throughout the country as well. Yeah.
I had some question about speech pathologists and also how you attract those professionals. How did you do to convince them to be a part of this project?
Yeah, so that's a very interesting question. So Manju Virk, who is one of our PhDs, she studies the things that move professionals to give this care, to provide this care, to want to continue doing so, and what helps them and doesn't help them in that. So we've just looked into that very well, and it's really an internal motivation it's people that are not afraid of doing something difficult, a little bit outside of the box, and yeah, just being a pioneer in some way, I guess. And as long as you facilitate these professionals in a good way as an organization, you make sure that they're not overburdened, that they have access to evidence, for example, but also to the time to reflect on what they're doing and to share their knowledge and experience with people in other centers, then they can keep going and going and going. But if you don't facilitate them well enough, they just, at some point, they go running. So we find that as you're, I mean, if you've got something to share to the outside world, that you're doing something that's working, then those professionals come to us and they really want to work there. If you maintain a healthy work climate. Yeah,
having a positive mind and understanding also that they have challenges on their parts.
Yeah.
And that's the reason why things are a little bit complicated. And it's not that they don't want, it's just that their resources can be limited and they don't have sometimes even the tool to be educated for that.
Yeah, but it also requires a certain kind of intelligence from the board of directors. So you really, I mean, if someone's looking at a nursing home or a rehab center and trying to organize it as it were a cookie factory, yeah, that's not gonna work. They really need to understand what you're doing, why it's important and valuable. And this required some, well, we sometimes call this moral courage from the people high up in the organization too. I mean, sometimes we really need to stick out their neck and say, well, this is what we're going to do, and we need to be facilitated in this, because otherwise, yeah.
I think you told me also that there is a constant communication, or there is at least an effort to have that constant communication between the different partners in this network, so that you have a monthly meeting, something like that. I'm sorry if maybe it's too much monthly meeting, but
no, well, there's a couple of ingredients there. So we have actually a weekly meeting, which is just a Monday morning, 30 minutes with all the PDOC specialized physicians, in which we discuss the patients on our waiting list and who's going where. But also we have just enough time there to share some, well, if we have trouble with specific medical problems or ethical stuff, then we can just exchange that there in a very low profile, easy way. And EENACOMA provides regular meetings every couple of months for both the people high up in the organization and the healthcare workers of different disciplines, and sometimes everyone together. So we know each other quite well, and these meetings are well visited because they're worth their time, because you know what's going on the different fields, but also what's happening in the financial departments. And we tend to organize these. We usually invite experts, for example, on tracheotomy or researchers who have something to publish. Yeah.
Okay. I think there is more question about these 4 centers and how many hours of therapy patients get. For example, in the United States, it's 3 hours a day. And then you have for 15 hours a week. There is also some question about what exactly that treatment involve. Is there any specific treatment that is administered, and how many CRSR that's rather an expert is doing. Is it frequently done, and how frequently is these assessments and diagnosis performed?
Yeah, so I would definitely invite people to just send me an email with the more technical questions. But in general, we tend to not have too many criteria about therapy duration, because for most patients, it can be very difficult how long you can keep someone's attention span intact in order to make it an effective session, right? So we find it important and useful to give a lot of autonomy to the therapist, just to see what works in a specific patient. But these 10 moments a week in the bin setting, for example, they are fixed, and they have certain, there's a specific number of hours, well, minutes really, dedicated to the patient themselves, and then for the stuff around it. So writing down what you've been doing, but also communicating with other parties. And a CRSR, once someone is in a diagnostic protocol, for example, they've been in a chronic setting that's not specialized, we really want to know what their level of consciousness is, so we can go through. Then we admit the patient to one of our specialized institutions. We do at least 5 CRSRs in 2 weeks. And after, obviously, looking at those factors that might influence their performance negatively. But during the rehabilitation process, most patients get a weekly CRSR in different moments in time, different settings, with family, various kind, well, whether they're standing up or lying in the bed, etc. So you have a whole set, which you combine then with your non-structured observations, which is particularly useful in patients who we all feel are conscious, but have a very big problem with language processing, for example. Sometimes you never get to the ceiling of the CRSR. But at some point, you should, we think, declare them conscious and say, well, this is mostly a problem of language function, so that they can go through rehab with rehab targeted at that.
Yeah, I think, what I found is that as an expert, I have been doing that for 25 years now. So it starts to be a very, I'm very sensitive when I do a behavioral assessment, and sometimes a little bit too much, meaning that it becomes hard for other other people in the team to actually obtain the same response, and sometimes even see this response. And I find it very challenging to just communicate that and make sure that they see that the same way I do, and they use that in their care. So how do you do when the patient is discharged and go to another ward to make sure that what you observe in an expert team and what you did as an expert team is kind of seen by the team over there and not disregarded because just they don't have the same level of expertise.
Yeah. So a very important instrument of that is the outreaching function of the specialized units, because what we've been promised we're going to get in January 2024 is money for our experts to visit the patients once they have been discharged. And the MET is very important in that as well. So for single questions such as what do we do with the way the patient is positioned in the wheelchair, for example, then that's just one thing that the outreaching function could do. But if there's bigger question following up on diagnosis, treatment goals, etc., that's what the MET is for. Yeah.
I think that there's a few questions about how do you reach consensus among the team members about diagnosis, and if you find also that repeating the CSR assessment is improving the diagnostic accuracy.
Yeah,
I could answer that, but I let you answer.
Yes. Oh, seems like a test now. So so we definitely see that just being it's such a luxury to have the patient around for so many days, right, or months even. So it's rarely that we really have when we disagree on a diagnosis. Very often you'll see that some therapists are noticing things before the others do, but we usually get out of that by doing the CSR, then intensifying the regime, and then we'll catch it at some point. So it's mostly if we are not sure if a patient is in unresponsive wakefulness syndrome or MCS minus, that we really try our best to get the accessory diagnostics. Because what we find is that there's hardly any real unresponsive patients. It's almost never happens, no. So if we find them, we always get a little worried. We're probably not looking right. Yeah,
no, and I think one thing that I found with time is that you repeat assessment. Okay, you have your 5 assessment, but actually there is a difference between having the diagnosis and what you find in these 5 assessments that could be practical in your therapy. In your therapy as an expert, but also in a therapy that is when you have a mobile team that would be practical or to use for this team. So, for example, I can find, for example, visual tracking, in a patient, I get all excited, it's MCS minus, it's not a vegetative state. Well, how do you first make sure that the team over there who, is less expert knows how to find it and how to use that in his therapy. But there is also the response to command. If among 5 assessments I have once when the patient responds to command, how do you use that as a therapist? Because you have only one occasion when the patient actually responded to command. So it means that most of the time when the therapist will show up, the patient will not be responsive. So it's
No, and then we very often experience that. And then in the PIN, time is really on our side, because it's just a matter of time. We can trial and error and see what the right direction is, what we should try to get the patient to respond in their most optimal manner. And I think what is a key as well is that we have a multidisciplinary meeting every week in which we just talk to all the patients. So everyone's on the same direction, knows what to notice, what to look for. And the family members they're not there during the meetings because of efficiency reasons. Otherwise it would just take much too long, but they're very much involved in the therapies. Usually they're present oftentimes in all therapies even, and we're just happy with that as long as they're very constructive. we help them with that too. So, and that means that there's usually not a complete surprise if you start talking about formal diagnosis and what the future of the patient is going to look like. Yeah.
I think that there is also a question regarding the total number of beds that you have in the 4 centers, expert centers that you have in your country.
Yeah, so in total we have about 20 beds now for the prolonged intensive neurorehabilitation, and between 10 and 14 for the early phase. And yeah, we're still trying to grasp how many patients there really are, because they pretty much, we do feel like pretty much everyone is now being referred to us. But when we started in 2019, then you had COVID, this really changed the epidemiology of prolonged disorder of consciousness a lot. So we're still working on that. Where it seems like usually this is enough, especially if we can get patients, if the EAN is is full, and we can put patients in waiting first in one of the PIN institutions for somatic optimization, diagnosis, family counseling. So it's really useful. It's really useful too. Then people are generally happy with the way patients are moving out of the hospital and into a setting where they can work on their recovery. Yeah.
I think that I will have a last question. It's a challenging question. I don't expect you to have a response ready, but how do you transfer this kind of model of care to kind of a American model of care that is actually based on private insurance? And
I think
it's a hard question. I saw that question. I was like, "Ooh, that's actually an ongoing discussion." But it's feasible. But it's just a question of thinking about it. Yeah.
I mean, you have all the expertise you need. I think that's one thing that you need to realize. I mean, looking at the Mohonk report that was written quite a little time ago, everything is in there, I feel. So it's really a matter of getting some of those people who are in charge of the money to really see what this is about and to care about it. And then, I mean, most people working in insurance, they want to go home with the feeling that they did something good for humanity at the end of the day as well. So but you have to get in contact, and on a very personal level, I think, to get something moving. And I guess you should then, in a complex situation as in the USA, but also in Belgium, I guess, just if you start small with and just show that it's possible, then at some point with perseverance, you should get enough momentum to get things really started on a bigger scale.
Yeah, I think that's very key what you just said, just having that relation with the insurance, and having that them to realize that it's actually these patients make progresses, but maybe the resources used to see these progresses are not the right one, or just trying for them to understand what this pathology is. And I think that there is also some discussion I had with the tier, Dr. O'Brien and her team were talking about that challenge and how that can be overcome with just having that relationship established and just having the right language, because sometimes we communicate in different ways, and we have to find what is the the argument that will be convincing to the other person, and that's sometimes something a little bit difficult.
Yeah, and I think a very obvious common ground is that nobody wants to be in a prolonged disorder of consciousness with no perspective of improvement, and that in order to get there, you need to make sure that you facilitate people in their recovery, but also that you talk about what you do if that recovery doesn't happen. And that's just a very normal and human conversation that you can have with pretty much anyone without getting in a super big fight. But
exactly,
if that's your starting point, I mean, everyone can relate to that, no matter what their profession is. So yeah,
like that is a conclusion for this webinar. Willemijn, thank you so very much. It was a very interesting talk, and I definitely will be in contact with you offline, because I think this is something, an initiative that should be happening in other places. So
thank you very much, and I hope to hear from every one of you.
Yeah, thank you so much. Thank you everyone for attending. It was a great time.
Okay, bye-bye.